I now have the honor to introduce our session speakers. Reid is the Director of Advisory Services practice at Kraft Healthcare Consulting, where she oversees reimbursement and operation services. Her responsibilities consist of reviewing and preparing Medicare and Medicaid cost reports and working with clients on other reimbursement opportunities, such as disproportionate share or DISH and provider-based options. Additionally, Katie performs healthcare operational assessments and operational projects such as review of hospital charge masters and physicians' fee schedules. Katie also assists the audit team at Kraft CPAs with healthcare-specific financial audits. Katie is partnered with the American Institute for Healthcare Compliance to develop a Medicare and Medicaid cost report bootcamp course. In addition, she worked with the IHC to create the Certified Cost Report Specialist credential, as well as its related education and testing. So Katie, thank you for joining us, and we look forward to your participation and presentation.
David.
Mertie is the president of Kraft Healthcare Consulting, LLC. With more than 25 years of experience in the healthcare industry, Scott consults on various areas involving third-party reimbursement, operations, and compliance for clients throughout the United States. Additionally, Scott provides expert reports and testimony for healthcare-related litigation engagements. His clients include hospitals, long-term care facilities, physicians, and other providers, as well as law firms. His previous experience includes working for the Nashville-based hospital management company and Nashville hospital system and other CPA firms. Scott regularly presents on a variety of healthcare topics to organizations such as the HFMA, MGMA, MGMA, and many, many other organizations, among others. He has also partnered with the American Institute for Healthcare Compliance to develop Medicare, Medicaid cost report bootcamp courses, just like Katie. In addition, he has worked with the AIHC to create certified cost report specialist credentials, as well as related educations and testings. So it's my pleasure to introduce Katie and Scott, and I'll turn it over to you.
All right, thank you, David. It's our pleasure to be here with all of you this morning. Been attending the Tennessee HFMA Fall Institute, I have for over 20 years, probably closer to 25 years. And it's generally always in Gatlinburg and always in October. So a little bit weird being in September and we're doing this virtually, but glad to be here and do it. But today is the first day of fall, so I guess we can go ahead and call it the Fall Institute.
And I was actually in Gatlinburg this weekend, so I got my Gatlinburg feel.
So some of our talking points that we're going to go over, we're going to briefly go through the federal fiscal year 2021 reimbursement updates. This will be kind of the first section. We'll be going over the short-term acute care hospitals, which is kind of the main guts in this, and talking about the actual annual update, which includes the wage index and DISH. And Katie's going to go over Medicare Bad Debts, a few new things, and then some core things that are relevant to really every Medicare Part A provider type. And then I'm also going to do a brief update on the annual 2021 updates for LTACs, psych facilities, and rehab facilities. After that, Katie will go through some frequently asked questions related to cost reports and everything that's been going on the past 6 months of COVID-19. There's been a lot of changes, a lot of issues that have come up, so she's going to go through a number of these things. And then finally, we're going to end it. We're going to tag team talking about some of CMS's flexibilities in order to fight COVID-19 that the providers have been doing. So prior to jumping into this, do you want to have a disclaimer that everything we say here, certainly is subject to change and it's as accurate as possible, but certainly things can change from the time we present to at some point in the future. So just certainly keep that in mind, but don't hesitate to reach out and ask us with any changes that may occur. So let's go ahead and jump in and talk about our federal fiscal year 2021 updates. The first thing I want to point out is all of this information that we're going over today is available on CMS's website. So I just kind of have a slide of cms.gov. I know a lot of people find it very difficult to navigate, but if you go to the next slide after you go to cms.gov, You click on Medicare, and on the right side, we're on slide 6 now, Mally. You'll see where you can select acute inpatient PPS. And really, you kind of hit that one, and then all this information that we're going to go over in the beginning of this presentation is all available there. And throughout this presentation, I'll kind of be pointing back to that a little bit, just to remind people that even though there's a ton of information out there, it is readily available if you know how to navigate CMS's website, as well as all available on the Federal Register. So, certainly don't forget that. And of course, you can Google and find stuff online, but it's all right there on CMS's website. All right, with that being said, let's go ahead and jump into the inpatient PPS or prospective payment system hospital update. So this update is released annually and becomes effective October 1st through September 30th. That's the federal fiscal year. So all inpatient Part A activities are updated on the federal fiscal year. Hospital outpatient and other outpatient activities for Medicare Part B will be updated on the calendar year, so January 1. So really everything we're going to talk about today takes place October 1st. So very timely for this presentation. The inpatient regs for IPPS were just released on September 3rd, just a couple weeks ago. This included the short-term acute care hospital update, as well as long-term acute care hospitals or LTACs, and then other inpatient PPS exempt providers such as critical access hospitals. CMS estimates that this final rule will increase operating capital payments by $3.5 billion over 2020. Of this, $3 billion is related to operating and uncompensated care. And I apologize, I do have a typo there. There should be a slash or an and between operating and uncompensated care, the UCC there on that second to last tab. And the other $500 million, approximately $506 million, is related to capital and technology add-ons. Now for this operating update, these payments are really going to be increased, what we call the DRG payment. The operating DRG payment is being increased by a total of 2.9% across the board for IPPS providers across the country. 2.4% of that is annual market basket increase. This is what we think of as an inflation factor. And then a half percentage point is related to a macro increase. Now, there is a 25% reduction of the market basket increase for providers not participating in the inpatient quality reporting program. Furthermore, there's a 75% reduction to that market basket increase for not being a meaningful use provider. So if you're not doing quality and not a meaningful use EHR user, then you're not getting that market basket update at all. So certainly keep that in mind. Slide 9 kind of shows that impact between urban and rural hospitals and teaching hospitals. So I mentioned it's overall across the board a 2.5% increase for all provider types. Now, if we look at just your general urban hospital, it is right there at that average 2.5%. Rural hospitals are a little bit lower at 2.7%. And of course, this is just averages across the country of an expected increase that providers will see. In major teaching hospitals, I know we have a number of people with Vanderbilt participating today. They're at 2.7%. Now the next slide, this is slide 10. It's a little bit convoluted. I got a lot on there. I'm not going to be going over all this, but I just want to point out a couple things. Again, this is kind of breaking down the geographic region and also by bed size. So we mentioned urban hospitals, a 2.5% increase, whereas rural is only a 2.2% increase. Now, if we look at the bed size here, depending on what provider type you are with, you can kind of get a better idea of where that is between urban and rural size. And then we kind of dive that down a little bit deeper on slide 11, showing the urban and rural regions that are here. If you go to the next slide, Mally.
And I actually think Mally's slides that we have up here on the screen are off one from what you have.
Oh, are they
Just,
off one number?
Yeah,
Oh,
off one number.
Sorry about that. But this slide shows in the east, south, central region, which is where we are in Tennessee, We are right at that that average for urban at 2.5 percentage points increase. And then the rural, so if we think of rural Tennessee, that's only at 1.9%. So Tennessee rural hospitals are not getting nearly as much as that average increase that we're seeing across the board. However, Tennessee urban hospitals are right at that national average at 2.5%. And I see now why our slides are off. We had that one slide inserted that had the sponsors on there. So the next slide really kind of breaks down this update for, this is for, again, your standard medical, surgical, short-term acute care hospital. The labor and non-labor portion of that update. So this is really what the base DRG payment is, and that DRG is going to be weighted based on the complexity of what is being done to that patient. But this table is in two sections, a top and a bottom section. The top section is for providers or hospitals where your wage index is greater than 1, and we really don't have any of those in Tennessee. And then, so really we're looking at table 1B, or the lower table. This is what we're seeing for most of our providers in the Southeast region. And so our labor portion for a hospital that is submitting their quality and is a meaningful use provider, hopefully all of our hospitals in this state are doing that. Their labor portion is $3,695.94, and the non-labor is $2,265.25. You'll see the next three columns kind of break that down, that reduction factor that I mentioned before, if they're not meeting those certain reporting requirements. Now, for those of you that are not real familiar with how to calculating a DRG, we kind of break out the labor and non-labor portion. The reason for that is a certain amount, in our case, approximately 62% of what CMS or the government says hospitals related to providing inpatient care, 62% of that is for wages, for paying your staff, whether it be your direct nursing staff, aides, etc. The remainder, the 38%, is going to be related to all your overhead costs, your bricks and mortar for the building, etc. So, labor is a pretty good portion, 62%. And those of you that, when you look at your financials, you know that, your labor is certainly your most expensive thing that you have on your financial statements. So what CMS does is they break that labor portion out based on where you are located throughout the country. So a hospital in New York City has a much higher labor than Nashville, Tennessee, or rural Nebraska. Those all have different wage indexes. That's the wage index portion of the cost report that is used to basically wage adjust this labor portion of your DRG. In the next slide, slide 14, shows our wage index for federal fiscal year 2021. The first line is for rural Tennessee. So if you're not associated with an urban area, your wage index, which you see in the right column, is 0.7108. And that's really saying that on average, the wages for providing care in hospitals in rural Tennessee is 71% or 71.08% of the national average. So you think of the national average being as 1, rural Tennessee is approximately 71% of the national average. Now we have different MSAs throughout the state, such as Chattanooga, Clarksville, Cleveland, Tennessee, etc. Very bottom, you have Nashville, Davidson County. I'm just going to use that as an example because that's where I'm physically located. But you see Nashville also has the highest wage index at 0.8741, or approximately 87% of the national average. So quite a bit higher, 87% compared to the 71%. And what's that saying is it's just more expensive to staff hospitals in urban Nashville than it is in other rural areas in the state. And then we have, again, our other MSAs that have different wage indexes. All this information is compiled from the cost report each year. So what makes up a particular MSA are all the hospitals within that region. For Nashville, it's Davidson County and all the surrounding counties. All those hospitals, all that data gets averaged together. So you want to make sure that not only your wage index data is reported accurately, but also you want to make sure that your neighbor hospital is reporting their data accurately too, because it truly does affect this wage index that ultimately affects your DRG weighting. So very important. But you see we're at 0.8741% for Nashville. You'll notice a couple MSAs such as Kingsport, Bristol, or Morristown, they're all at 0.7108, or they're at that rural that rural rate. And the reason is if a particular urban MSA that's deemed urban, their wage index is actually below the rural rate, you get that rural rate. So that's why they're at the same amount as the rural. Going to the next slide briefly, the capital. So we were talking about the operating portion, which gets wage adjusted. We also have a capital portion, and that base rate is $466.22. So that's the capital part of your DRG payment. And of course, that gets weighted just the same as the operating portion based on the particular DRG that's being done. Now, a big portion of hospital, or potential a big portion of their reimbursement in addition to the DRG is an outlier payment. And in a nutshell, what an outlier is if a hospital incurs a higher cost to provide this service than what CMS deems what the average cost would be, if you go over a certain threshold, you're going to get an add-on payment. And certainly it's always good to get that add-on payment, but it's not necessarily the most efficient thing, because for whatever reason, it's whether it be a longer length of stay, it's costing the hospital quite a bit more money to have that patient in there. So this threshold gets updated every year, and want to keep in mind that really everything we're talking about is also wage adjusted. So depending where you are in the state or where you are in the country, you got to make sure that you're adjusting this threshold to your particular wage index. But if your costs for providing that service exceed 80% of the threshold, then you're eligible for this outlier payment. And our current outlier threshold for fiscal year, or not our current, but will be effective October 1 for federal fiscal year 2021, that threshold is $29,000.51. So how do we determine that cost? Because your billing charges, what happens is you're using a cost to charge ratio. That's the CCR that's listed there. The cost to charge ratio that it comes from your previous year's cost report. That is what is being used that CMS or the MAC uses to determine if you meet that threshold. So it's going to be your gross charges times that cost to charge ratio, giving you what your estimated cost is. And if that estimated cost is 80% of that $29,000, of course, that's going to be weighted, then you're eligible for that threshold, or 80% of the difference to meet that to get that reimbursement. Now, the outlier threshold in this current fiscal year that we just are finishing in fiscal year 2020 was $26,552. So you see it went up about $2,500, and that's really not a good thing for providers. The threshold goes up, that means it's more difficult to meet that threshold to get that additional outlier reimbursement. The last point here that I want to mention is CMS is doing outlier reconciliations, and this is when you have a previous cost report that essentially, when it's getting finalized, if there's been any certain changes to that cost report related to costs or charges that could materially affect the cost to charge ratio, that can potentially affect your outlier, and what an outlier you got paid in a federal fiscal year 2 years ago, as this cost report is getting finalized, you might not meet that threshold now. And so it's very important to be ready if that does happen. We worked with a provider in another state that essentially they came back, their cost report had gotten adjusted, and they had several $1 million owed back related to outlier payments that CMS was recouping as a result of that cost to charge ratio. So it's very important to be ready for that. And that cost to charge ratio, again, is a function of your charges and your costs. And that's what on the next slide, Those of you that have heard me speak before have heard me really get on the soapbox about how important accurate cost to charge ratios are, and that really comes from having an accurate cost report being prepared. And I hear this from a lot of people. We're prospective pay. We're getting that flat DRG for inpatient, that flat APC for outpatient. Why does it really matter? Why does this cost report matter? Well, there's a number of reasons. That cost to charge ratio ultimately is the result of preparing that cost report. Certainly, if you're a critical access hospital, you're 100% cost, so that's critical. But other provider types, whether it be sole community or a Medicare dependent hospital, those cost to charge ratios are used in some of those calculations. They are also used to determine, CMS uses the cost for providing care to determine what future reimbursement rates are going to be. They compile all the costs from all the hospitals, and that's how future reimbursement rates are set. And I have this highlighted in the bottom bullet point. They're used for uncompensated care calculations, which is very important to hospitals now that qualify for DSH and uncompensated care. And we're going to talk a little bit more about that in a few minutes. But I really get on a soapbox about this. Slide 18. There's a number of things that the cost report or the cost charge ratio affects, and certainly the outlier is a very important function. So I'd like to throw that out there and kind of ingrain that in people's minds, how important that is. And slide 19, I have on there saying it all starts with worksheet A. Worksheet A is where you're summarizing your expenses for the year on the cost report, and then we go through reclassifications, adjustments to remove non-allowable costs to get what our true allowable Medicare costs are. Then slide 20 shows where we're allocating those overhead costs. And this is really the fundamentals of the cost report to get what we call cost finding. And then slide 21 goes to worksheet C, where we're putting in our gross charges. And that's ultimately where we're getting our cost to charge ratio. We're getting those allowable Medicare costs or allowable costs for Medicare purposes divided into our gross charges, and that's how the cost to charge ratio is calculated. Now, I want to reiterate that we're using gross charges. And again, I hear a lot, gross charges, what do they matter? It's kind of an arbitrary number that's going on the bill, but we're getting reimbursed that DRG rate or whatever contracted rate is with the insurance company. So, a lot of people focus on what our net revenue is or our net charges, but for these cost to charge ratio purposes that have a number of not only direct but indirect reimbursement impacts, that gross charge number is very important that you have set up in your charge master. So we highly recommend having your charge master reviewed every couple of years, because they can certainly start getting out of whack, and make sure that it is appropriate for your particular facility in order to make sure that you do have proper and reasonable cost to charge ratios that can help you years down the line. So I'm going to get off my soapbox on the cost to charge ratio. I just always like to stress that. I know those that have heard me speak before, I've been on that soapbox before, so you know all about that. So slide 22, we're going to talk briefly about DSH reimbursement, then hop over to uncompensated care. Last year at the Fall Institute, I think we did pretty much a good portion of that section on DSH. There really has not been a big change related to DSH and uncompensated care other than some of our updates. That's what I'm going to highlight. But just as a reminder, if you're a short-term acute care hospital that qualify for DSH, there's really two functions. It's your disproportionate share function and your uncompensated care. And the uncompensated care has become a bigger piece. But DSH is basically a function of your Medicare supplemental days, or what we call your SSI, divided by your total Medicare days. That's our SSI ratio, plus our Medicaid and Medicaid eligible days divided into our patient days. So that's really gives us our Medicaid or our DSH percentage. And if we go to slide 23, you can see in that center column where it says threshold, if that amount falls in in between any of these particular categories based on the type of hospital you are, urban, less than 100 beds, or urban greater than 100 beds, and different categories, you have a different DSH calculation. And the right side of this is the DSH calculation. And don't worry, this is not going to be on one of your poll questions for CPE. Calculation, but this is all done in the cost report based on the criteria for your SSI ratio in your Medicaid days. Now, slide 23, I kind of note with the Affordable Care Act, DSH, used to be a huge factor for hospitals, but part of the Affordable Care Act was to limit the DSH reimbursement to really 25%, and the remainder of that calculation focuses more on uncompensated care. So let's talk about uncompensated care a little bit more. I did want to point out slides 25 and 26. Again, kind of seeing where the SSI ratio is. I mentioned on the website, Medicare or CMS.gov, you go under Inpatient Acute, and then you can click on disproportionate share. And then slide 27 shows all these options that you can choose from. So the SSI ratio is updated every year, and it's always a couple years behind. So you want to use your most recent SSI ratio that's available, and this is facility specific. So you can click on here to find your most recent SSI ratio. It's listed out by provider number, so it's got every hospital in the country. You find your provider number, and then you find your SSI ratio, and that's what's used in your current year cost report that you're filing. Again, these SSI numbers are always a couple years behind, so before Medicare finalizes and settles that cost report, they're going to use the SSI ratio for that current year. It's always going to be a couple years behind. That's why if you're a DSH hospital, you're going to, it always takes a couple years to settle that cost report. Time-wise, okay, we're going to buzz through now and talk about uncompensated care. Then I'm going to hand it over to Katie. So we're at slide 30 now. And uncompensated care, again, I mentioned this became a much bigger issue under the Affordable Care Act. There's different factors that go into this calculation. Slide 30 shows our factor one. This is a national number that gets updated every year. The federal fiscal year 2021 number is at 11 billion. And that's what the government deemed is going to be available for uncompensated care throughout the country. Now we're backing out 25% of that, which is available for DSH. It was 15 billion, but we're backing out 25% to get to the 11 billion. And then we have another factor, and this is what CMS, this 72.86, deems as the actual percentage used for uncompensated care. So that's getting us to that 8.2 billion that you see there. And that is what is eligible for all hospitals across the country to get a little slice of that pie that are eligible for DSH uncompensated care. Now, every hospital has a little bit different in their uncompensated care calculation. So if we go to slide 32, this again is published every year. And I kind of took a slice out of just some Tennessee hospitals. There was provider numbers all starting with 44. And so there's about a dozen or so. But the column where it says factor 3, it's a percentage. Most of them start with 0.000. And then there's a small fraction behind that. That is what gets applied to that 8.2 billion. And it's facility specific, and that's the percentage that your hospital will be obtaining for uncompensated care for federal fiscal year 2021. Now, all that data comes from, for factor 3, that small fraction comes from your worksheet S10. And again, this is a very important worksheet. It used to be, is just data we submitted, and this is our bad debts and our charity care and our care we provided for Medicaid patients is for more informational. Now it actually means something. So some of you have maybe even gone through some worksheet S10 audits, and what Medicare is doing is ensuring that that data is accurate, because that's where your that fraction comes from to determine what you're eligible for that uncompensated care. Very important. What they're using for federal fiscal year 2021 is your uncompensated care data that was reported on your 2017 cost report. So you notice that's almost 4 years in arrears they're using that data. Going forward, they're going to use your most recent available audited worksheet S10 data. I know that's a lot thrown in there, but that's really an update for all the short-term acute care hospitals. Now we're going to turn it over to Katie to talk about Medicare bad debts.
So I'll cover this section, Medicare bad debts.
And actually, I don't mean to cut you off. I think we have a polling question.
Oh, okay.
Before we do that, I forgot. So Mally, I think you had a polling question. And those of you that need CPE, you need to complete these 3 polling questions throughout the presentation. I think you can see it there. The SSI data is updated for the calendar, every calendar year. Is that true or false? And I think you have about 30 seconds or so to answer that, and then we will jump into Medicare bad debts.
Scott, for CPE reasons, we have to keep these up for a minute exactly. So
Okay.
we're at about 40 seconds, so there's about 20 seconds left. So get those answers in.
Very good. All right, look like we have about, I'm not sure if they want me to go over the questions, but 44% said true. The rest said, does it say 44?
Yes.
Yeah. And then the answer is true. That SSI percentage is updated every year.
All right, so I will be covering bad debts. No matter your facility type, whether you're an FQHC, a hospital, other facility types, you're going to deal with Medicare bad debts. So the 2021 IPPS final rule, CMS has codified its bad debt policies that were included in Chapter 3 of the Provider Reimbursement Manual. Most of what I'm going to cover is not new information. It is policies in the Provider Reimbursement Manual, the PRM, that are now being codified. So if you're familiar with the subject, this is probably just going to be reiteration of what you already know. But again, this affects everybody, and this is money laying on the table for you guys if you have Medicare bad debt. So this is important to cover. As a little background, Medicare pays 65 cents on the dollar for every Medicare bad debt that you claim. We have 4 criteria to be an allowable Medicare bad debt. You must meet all of these. They're listed here. The debt must be related to covered services derived from deductible and coinsurance amount from beneficiaries, Medicare beneficiaries. The provider must be able to establish that reasonable collection efforts were made. This is a bulk of what we're going over because they have addressed this subject since it was so vague. The third is the debt was actually uncollectible when claimed as worthless. And the fourth, sound business judgment established that there was no likelihood of recovery at any time in the future before you can claim that bad debt. So reasonable collection efforts. Before this update, like I mentioned, they had a very limited statement concerning what that actually meant. It just basically says you must be able to establish that a reasonable collection efforts were made. Additional requirements were outlined in the PRM, so CMS is proposing to add these to the regulation. They have defined non-indigent beneficiaries since your collection efforts are made on those top patients. So they have they intend to give a more precise meaning to that term, and basically they took a couple of sentences to say you're not eligible for Medicaid and you're not determined to be indigent by your provider for Medicare bad debt purposes. They've also addressed billing timeliness. Let's see, prior to October 1, 2020, you must issue a bill to the beneficiary or the party responsible on or shortly after discharge or death of the beneficiary. So the provisions on or after October 21 are intended to give a more give more clarity to that meaning of shortly after. So we have that defined here on the slide. So on or after October 20, October 1, 2020, a reasonable collection effort must involve issuance of the bill to the beneficiary or the party responsible on or after 120 days after the Medicare remittance advice date, the date of the remittance advice from secondary payer, or the date of the notification that the beneficiary's secondary payer would not cover the services. So in my past experience with Medicare bad debts and audits, this actually wasn't defined in the provider reimbursement manual or the Federal Register, but the max typically use 90 days. If any of you have been through a Medicare bad debt audit, you'll get your Excel spreadsheet back, and there'll be a couple of columns out to the side that the auditor has made, and they take your date of first bill to your beneficiary less your Medicare remittance advice date, and if that was greater than 90 days and that was considered untimely billing, now they have defined that, and it's 120 days. So this 120 days, don't get that confused with the 120-day rule. If you deal with bad debts, you're probably familiar with this, but I guess that will be a easy way to remember both of them. Timely billing is 120 days, and your reasonable collection efforts is also 120 days, what we mentioned, the 120-day rule. So basically, what 120-day rule means is that you can't write off a bad debt until you've collected upon it for at least 120 days after the date of first bill to the patient. So right here, the codification, a bill cannot be considered uncollectible until 120 days have passed since your first attempt to receive payment. We need to know if you receive partial payment, then that starts this clock over again. And that's within your cost reporting year. So that starts your 120 days over. If you don't have any payments on that, you consider it uncollectible, you put it on your bad debt log, and you actually receive a payment in a subsequent cost reporting year, then you have to offset that payment to the accounts that you're claiming in the subsequent year. So continuing on with reasonable collection efforts, let's see, we're on the same slides. You have to put forth similar collection efforts, no matter whether your beneficiary is Medicare or non-beneficiary. You have to treat all bad debts the same and take the same actions to collect on those accounts. CMS responded to comments on this that it's a long-standing policy. It's a long-standing policy. So this is nothing new. It was in the provider reimbursement. People have been doing this forever. So this is a retroactive policy. I forgot to mention that a lot of these points that I'm going over, these are retroactive. They're not. Some of these are going in as of October 1, and some of them are going to be retroactive. But that's because that CMS said that these have been policies forever, and that this is going to provide clarity and going to remove confusion for provider reimbursement review board appeals and things like that. So on down to, I guess it's your slide 38. It's now in the codification that you have to document those efforts. You have to provide bad debt collection policy, your account history, show the dates that you've tried to collect upon those accounts, collection letters, reports, telephone calls, so on and so forth. But you have to be able to provide this to auditors if they ask for it, and they will ask for it. So moving on down, determining indigency. So these are for beneficiaries that are not Medicaid eligible. The hospital must determine the indigence of the patient. I'll get this out in a second. Not the patient. The patient can't come in and tell you they have no money. You actually have to analyze their resources, their assets, their liabilities, income, and expenses to determine their indigence. And if indigence can be determined based solely on income and assets, no review of expenses and liabilities will be necessary. This is kind of new for this update. And also in the past, there was some wording that said, you had to be it implied that you had to continuously monitor whether a change or not has happened. Well, that was unrealistic. A change in their financial condition, that was unrealistic, and CMS acknowledged that and says that monitoring for a change in financial status once indigence is determined won't be required, though if you become aware of a change in financial circumstances, you have to take that into account. Moving on to slide 40. So this is talking about dual eligible beneficiaries. Dual eligible is Medicare primary and Medicaid as a secondary, also called Medicaid crossovers, or Medicare crossovers, I'm sorry. Some states pay little or nothing towards a dual eligible beneficiary's cost sharing. And this has, we've had some questions from our clients in the past, because if you deal with Medicare bad debts, then you will be familiar with a must bill policy. So, but to back up, any amount that the state is obligated to pay, either by statute or under terms of its approved Medicaid state plan, will not be included as a Medicare allowable bad debt, regardless if the state actually pays that obligated amount or not. So if the state's obligated to pay, you can't claim that as a Medicare bad debt. However, if the Medicare deductible and coinsurance amount is not, the state's not obligated to pay that amount, then you are able to include that as a Medicare bad debt. What I was mentioning earlier, kind of got ahead of myself, is this must bill policy. So in order to put those on those dual eligible bad debts on your bad debt log, you must go ahead and bill the state whether you're going to get paid or not. And we've had clients that have had issues with the state not providing the right documentation, when it comes time for audits. So the state, or CMS, now says if the remittance invoice is not furnished by the state, there are alternatives to the must bill policy that you can provide. The state Medicaid notification, you have to provide all of this. The state Medicaid notification that the state has no obligation to pay the beneficiary's Medicare cost sharing, or notification evidence the provider's inability to enroll Medicaid for purposes of processing a crossover cost sharing claim, documentation setting forth the state's liability or lack thereof for Medicare cost sharing, and documentation verifying that the beneficiary's eligibility for Medicaid for the date of service. And last but not least, on our bad debt topic, is Medicare has addressed the accounting standards topic 606 under revenue recognition. Under 606, an amount representing a bad debt would generally no longer be reported separately as an operating expense in the provider's financial statements, but will now be treated as an implicit price concession and a reduction in patient revenue. So they have codified this and said that bad debts must not be written off to a contractual allowance account, but it must be charged, I have charges on here, but it must be charged to an uncollectible receivables account that results in a reduction of revenue. So again, a lot of this is not new information, but we really urge you to look at your bad debt policies, look at those processes that you have in place now. Want to make sure you're following those and making sure that they are up to date with what is being codified as of the 2021 final rule.
All right, I think we'll do our next polling question. So Mally will get that up on the screen. Thank you, Katie. And while you're all taking a minute to answer that polling question, I do want to remind everyone that if they would like to, copies of this, if you'd like copies of our presentation today, we know there's a lot of stuff we're going over, a lot kind of thrown at you, but if you'd like copies, I would be happy to send you a copy to Katie or me, an email. It's probably going to be posted on the Tennessee HFMA website as well. So we'll make sure you get it one way or another. And we're certainly going to try and have time at the end for Q&A, but if we don't have time to answer everything, then
feel
certainly,
free to email us.
Shoot us an email and we'll be happy to get back with you. Let's see what that polling question is. Medicare can audit and adjust your uncompensated care schedules. True or false? Medicare can audit your uncompensated care. And that answer is true. It looks like most of you got that right. All right, so let's go on to slide 43. And I'm just going to touch on this on price transparency. I know this has been, a hot topic with this coming out, and someone is speaking on this. I believe tomorrow there's a whole presentation on price transparency. So I just want to, kind of hit two bullet points here. But starting with cost reporting periods ending on or after January 1st, 2021. So basically next year's cost reports for most of you. The hospitals are going to be required to report, and I put this in quotes, but the median payer-specific negotiated charge for all Medicare Advantage payers, and this will have to be reported by your MSDRG. So this is something that's going to be very new. It's included in this price transparency. So your Medicare Advantage contracts are going to have to be submitted. And beginning in a couple of years later, in fiscal year 2024, CMS is going to be adopting a market-based MSDRG relative weight methodology that's going to utilize these payer-specific negotiated charge data. So basically, your Medicare Advantage plan contracts are going to mean something in future weighting of DRG. So something to keep in mind, and I know there is a presentation tomorrow, so they'll probably cover a lot more detail on that. So the next couple slides, I'm just going to take a few minutes and talk about the updates for other provider types besides the short-term acute care hospitals. I know we spent a good portion of the beginning of this presentation on, but other provider types also, other inpatient providers also have these same updates. LTACs are essentially getting a 2.3% increase. If you're not recording your quality data, they're going to take 2% of that out, so you only get a 0.3% increase. And you can see what that base payment rate is there at the table at the bottom if you're reporting it versus if you're not. Slide 45 talks about that outlier threshold. Again, we have a different outlier where the threshold amount for LTACs is the same as short-term acute care hospitals. And again, it's just very important. You see me kind of preaching this again about those cost of charge ratios. Very important. Next slide goes to our inpatient psychiatric facilities. And all these are relevant if you're a freestanding psych or rehab facility, or if you're a hospital that has a provider-based psych unit or a rehab unit. But psych is being increased by 2.2%. Now there is always for psych is reimbursed, quite a bit differently than our short-term and long-term acute care hospitals, as it's a per diem. But there's a 17% rural reduction factor if you're a psych hospital in a rural area versus urban. So pretty big difference. And then everything is still wage adjusted. So you got this 17% reduction in a rural area on top of your wage index. But the right column shows your base rates for federal fiscal year 2021 compared to the year we're just ending in 2020. The next slide shows those outlier thresholds again. And you can see that there's a threshold for your first 9 days that a psych patient is in, and then any days over 10 days and above, it's a different percentage to meet that threshold. The threshold is $14,630 for 2021. This actually went down slightly from the fiscal year we are just ending, which is a good thing for behavioral facilities. Threshold went down and didn't jump up nearly as much as med-surg hospitals. So you have the ability to meet that threshold more so. And again, be ready looking for these outlier recoupments. And I say recoupments, potentially you can get additional money back to you, but in our experience, or at least situations we've been brought in, it's been recoupments. But I guess people aren't complaining when they're getting money. Slide 48. Same updates for FQHCs. We're at 2.4%, and again, a 2% reduction for not meeting your quality data. The table there kind of shows what this update is for that base rate, and then of course that is weighted based on why you're in the inpatient or rehab facility. Slide 49 goes over our outlier thresholds, and the threshold for rehab is $9,300, which is a pretty big jump from $7,900 this past fiscal year. So again, that's not a good thing for rehab providers. Threshold has gone up, makes it a little more difficult to get to. And this is the last time you'll hear me say that about the cost of charge ratios on that last thing. But again, very important in meeting those thresholds. Last thing for rehabs is a lip adjustment. That's your low income patient. It's basically the rehab hospital's answer to disproportionate share. The adjustment factor essentially has not changed. So it's the same adjustment factor that we've had in the past, and the calculation is there. But you do want to make sure, it's a function of that SSI percentage that is updated every year. Rehab hospitals do have a separate SSI from med-surg hospitals. So when you're on CMS's website, go to your inpatient rehab facility tab, and then from there you can find the SSI ratio for rehabs. All right, now we're going to go to our next section of our presentation. These are really going to be frequently asked questions related to cost report issues that have come up with the COVID-19 over these past 6 months. So I'm going to turn it back over to Katie now.
Yeah, and again, I know we're big on telling you where to get this information, but that is important. So you can go back and read all this stuff verbatim from CMS themselves. So if you go to CMS homepage, about CMS, emergency preparedness and response operations and current emergencies, you'll see all this stuff about COVID. And they have a PDF. It's called CMS COVID Frequently Asked Questions, and they have all sorts of topics in this PDF. It's a few hundred pages. We're just going over specific cost report issues right now, but I urge you to get on there and look around at your facility type if you haven't already. Slide 52, CMS did extend cost reporting deadlines. All those have passed except for your February 29 cost reports, and those reports are due at the end of this month, 9/30. As of right now, there are no more extensions. Just keep that in mind that we are back on track on regular deadlines. What about provider relief fund payments? We get this question a lot. For the revenue side of things, report your PRF payments on the cost report statement of revenues just for informational purposes. Title that as COVID-19, PHE, Public Health Emergency, PRF, and report on these following lines for your specific facility type. What about the expense side? Should we offset PRF payments? Nope. Providers should not adjust expenses on the cost report based on payments received. Should your PRF payments, amounts for lost revenue not directly attributable to patient-specific claims, be used to offset Medicare expenses on the cost report? Nope, that is the same. And what about S10? How does this affect S10? Should hospitals report charges reimbursed through that program? The uninsured piece of that program on worksheet S10. The PRF program has a few different buckets, but for subsection D hospitals, which are general acute care short-term hospitals that receive payments from this uninsured program, don't report those charges on S10. The Small Business Administration loan forgiveness, this is where PPP comes in. Report your forgiven amounts on the cost report statement of revenue, same as PRF, on those same lines, so you can refer back to that slide. And if you have any interest on those loans, you just treat that similar to other interest expenses on the cost report. On the expense side, same as PPP, or same as the PRF payments, you don't offset expenses. This would have really affected facilities like critical access facilities. It would have just drained all their allowable expenses. So that's a really good thing that we're not offsetting any of that. On to slide 59. What if you as an employer deferred your share of Social Security tax in accordance with the CARES Act? If you did this, this deferral can be claimed as an accrued liability and expense on your cost report in the year where the cost was incurred. However, if your PPP loan or SBA loan was forgiven, then you're not eligible for that deferral relief. We're going to move on now to flexibilities to fight COVID-19. There are several different PDFs on the CMS website that goes over your facility type, and we're just going to highlight a few of them now that we thought was pertinent to mention.
And before we do that, let's do this last polling question.
Okay,
So Mally, if you want to put up the last polling question, and then we will wrap this up.
You must wait 120 days after the collection period for all Medicare bad debts to claim all Medicare bad debts.
So Katie just talked about that. So you'll have a minute to answer that question, and that'll be this is the third and final polling question. And again, those of you that need CPE, you are required to answer these 3 polling questions. You don't have to answer them right, but you need to answer them.
And we have a few more slides left. Again, these are things that we've highlighted. We'll just buzz through them. I know we only have a couple minutes left.
Yeah.
A lot of information we're trying
There's
to
a lot of information.
smush in there with updates and COVID related information as well.
Again, any questions, we're more than happy to answer questions. If you email them to us, we're more than happy to get back with you. I see there's a lot that have come up on the chat box, and but we obviously won't be able to get to all those now. So the answer looks like most people said true, and you actually do not need to wait 120 days for all Medicare bad debts. The key there is we have our Medicaid crossovers that don't have to go through that waiting period.
And I don't guess we said that explicitly, but if you want more information, okay. If you want more
It was in
information
this
about
slide.
that.
It was a trick question. I came up with that question, not Katie. All right, do you want to do this?
I'll just let you.
Okay. So flexibilities to fight COVID-19. So teaching hospitals for the duration of COVID-19, basically for the epidemic, a teaching hospital that sends residents to other hospitals would be able to continue to claim those residents in the teaching hospital's IME and GME resident FTE count. So a lot of these things that we're going to go over, you know, the government kind of laxed a lot of regulations that typically are in place in order to help hospitals stay open and treat patients during this epidemic. The presence of residents in non-teaching hospitals will not trigger the establishment of IME or direct GME FTE resident caps at those non-teaching hospitals, as well as your beds temporarily added during the epidemic for COVID-19 will be excluded from the calculations to determine those IME payment amounts. So the hospitals that are doing emergency, having to add beds in various locations, you know, not going through all the hoops that generally you would have to go to. Medicare is saying that's fine and it's not going to affect any of these counts.
And we're actually at 11 o'clock right now. I don't know if we have any leeway to go over a minute or two.
Yeah, Mally, are you okay if we continue to go for a few minutes?
Yes, everybody has their CPE credit. So if you want to take just a couple extra minutes, they've all answered those polls. So if you need to run, you will be counted for CPE credits at this time.
Okay, yeah, we just got a few more slides to go over. So critical access hospital bed counts and length of stay. I mean, generally a critical access hospital has to be limited to 25 beds. Again, in these, you know, crazy times that we have, critical access hospitals have been able to add additional beds to treat patients, and that's not going to count against them. They're not going to lose their critical access status or going over that 96-hour limit for the average patient's length of stay. As well as the location, CMS is waiving requirements that the critical access hospital has to be located in a rural area with the mileage from another facility. And this is because there's been, you know, emergency facilities established. And so, you know, the main goal here is to treat patients and not worry about some of these regulations during this epidemic.
We've got a lot of questions from our FQHC, RHC clients about telehealth visits.
You wanna?
Yeah, I'll just do this because I've got a lot of questions personally. But telehealth services are allowed to be included as those visits. So keep that in mind. They generally require the use of interactive audio and visual technology. However, during this epidemic, some services can be used using audio only, and we've included a link on slide 63, I guess, of those services. Scott, you can go over just a last few little bullet points there for FQHC, RHC clients.
Yeah, so there's been some things, slide 64, this is kind of in this flexibilities about the workforce. Home nursing visits, so rural health clinics and FQHCs, as well as there's another tab just about physician practices as well, essentially are able to make home nursing visits with fewer requirements. And as long as there's a shortage of home health agencies, rural health clinics and FQHCs are able to go out and do these nursing visits that a home health agency typically would be doing during this epidemic. However, keep in mind, just a nasal throat culture is not considered would not be able to be billed as a nursing visit. CMS is also waiving, it says waiting, that's a typo, sorry about that, waiving staff requirements that a nurse practitioner or physician assistant or any certified nursing midwife may be available to furnish patient care at least 50% of the time in the rural health clinic or FQHC. There's typically a certain regulation with that 50% limit. That's being waived during this epidemic, as well as certain physician supervision requirements for nurse practitioners. CMS has also established a facility without walls. This is, again, just being able to treat more patients during this epidemic. It's a temporary expansion of sites. They're allowing waiving requirements to expand service locations to meet the needs of beneficiaries and provide provider-based rural health clinics associated with a hospital with fewer than 50 beds. Typically have that payment limit, but they are related to the, they're exempt from that to avoid any bed capacity increases during this epidemic. Patients over paperwork. This is one that seems to make a lot of people happy. But a variety of these, again, these regulations are being waived. Some of these include some of the stark regulations that we've been hearing so much about over the recent years about the physician self-referral programs, but they're waiving a lot of these in order for these physicians to be able to see patients. So some of these include the fair market value waivers. Providers can support each other financially to ensure the continuity of healthcare operations. Facilities can provide benefit to medical staff, such as doing their laundry, giving them meals, childcare, et cetera. Facilities are able to do that free for the staff and not have it be offset costs on the cost report and all that kind of stuff during this epidemic. Physician-owned hospitals that have been grandfathered in can temporarily increase their number of licensed beds. Otherwise, that typically is prohibited under the Stark Law, and relax restrictions of group practices providing care in a patient's home. CMS also provided an accelerated advance payment in order to help cash flow for healthcare providers. I'm sure a lot of you have seen that, some of that cash influx, which hopefully has been beneficial to all providers. So with that, I don't think we have any time for questions, but anything in the chat log, I think will be logged, and Mally can send that to us, and we'll be happy to get back with you, or feel free to email us. Our contact information is right there, smertie@kraftcpas.com or kreid@kraftcpas.com. It was a pleasure to speak with all of you today. Sorry, again, it's virtual and we're not in person. We certainly missed that face-to-face interaction, but excited for this first virtual Fall Institute. So thank you all very much.